Welcome back to my series on the ICD-10-CM coding guidelines for 2021. If you are just tuning in, make sure you go back and watch the first few videos in these series. They will be added as a playlist on the front page of my channel. If you are new here, hi, my name is Victoria. I'm a medical coder, auditor, educator, and content creator. And on my channel, I am here to help you be successful in your medical coding career. So let's get on to some of the chapter-specific guidelines today for neoplasms. So I actually had to check my phone to see where the heck we ended up last time. So it looks like we are currently on Chapter 2, Neoplasms. So let's skip on through there. That's the great thing about the PDF is you can skip ahead with it. So Chapter 2 is Neoplasms. They start with code C00 through D49. One of the things you can think about is these are a lot of the cancer codes. So if you think of C for cancer, those codes that start in C are likely in the neoplasm section. So Chapter 2 of ICD-10-CM contains the code for most benign and all malignant neoplasms. Certain benign neoplasms, such as prostatic adenomas, may be found in specific body systems. So not in this code range, they might be in their specific body system chapter. To properly code a neoplasms, it's necessary to determine from the record if the neoplasm is benign, if it's in situ, malignant, or of uncertain histologic behavior. So benign means it's non-cancerous. In situ means it's cancerous, but it's not spreading, it's not going anywhere, it's like encapsulated and not going to spread in other areas. Malignant obviously is cancerous, and then uncertain histologic behavior means that it's been sent to pathology and we're like, I don't know what the heck it is, versus unspecified, which means the provider didn't document the specification. So this is what you'll find in your neoplasm table. So if you look over here in your book, this is your neoplasm table, and it is what you will see when you are looking up codes. Primary malignant neoplasms overlapping site boundaries. A primary malignant neoplasm that overlaps two or more contiguous, meaning next to each other sites, should be classified to the subcategory or code that ends in .8, which means it is an overlapping lesion, unless the combination is specifically indexed elsewhere. So if there's another code that specifically indexes that combination, then you wouldn't use that, you would use that combination code. So unless the combination is specifically linked elsewhere, for multiple neoplasms of the same site that are not contiguous, not next to each other, such as tumors in different quadrants of the same breast, you would code each site with different codes. So if there's a right upper and a right lower, you would use two different codes for those different tumors of the same breast, but in different quadrants of the same breast. Malignant neoplasms, overlapping site boundaries, we went over. Malignant neoplasm of ectopic tissue. So malignant neoplasms of ectopic tissue are to be coded to the site of origin mentioned. So if it's an ectopic pancreatic malignant neoplasm involving the stomach, it's coded to malignant neoplasm of pancreas because that's where it originated at. The neoplasm table in the alphabetic index should be referenced first. However, if the histological term is documented, that term should be referenced first rather than going immediately to the neoplasm in order to determine which column in the neoplasm table is appropriate. So for example, if you have something like adenoma and you refer to the alphabetic index to review entries under there, it will say see also neoplasm by site benign. But if you look under something like keratoses have their own specific designations in the alphabetic index. So you wouldn't go to the neoplasms for the table for those because they have their own specific codes. Same thing with cysts. Cysts aren't coded by the neoplasm table. They have their own alphabetic index entries. And then if you do code by the neoplasm table for those certain ones, like a malignant melanoma, or not, yeah, malignant melanomas would be referenced in the table. Always check then in your tabular list to verify any of those character extensions. Treatment directed at the malignancy. If the treatment is directed at the malignancy for that encounter, you designate the malignancy as the principal diagnosis. The only exception to this guideline is if a patient or admission or encounter is solely for the administration of chemotherapy, immunotherapy, or external beam radiation therapy, then you assign the code Z51. That category code is code as the first listed or principal diagnosis, and the diagnosis or problem for which the service is being performed as a secondary diagnosis. When treatment is being done at the secondary site, so the patient's being admitted for treatment primarily at that secondary site, the code for the secondary neoplasm is designated as the principal diagnosis, even though we have a primary neoplasm. That encounter that we're treating that patient for that day is for the secondary. So the secondary actually gets coded first, and then the primary malignancy gets coded after that. For coding and sequencing of complications associated with the malignancies or with therapy thereof are subject to these following guidelines. When the admission or encounter for management of an anemia associated with a malignancy and the treatment is only for the anemia, that's when the appropriate code for the malignancy is sequenced as the first diagnosis, and then we code anemia. If it is anemia associated with chemo, immuno, or radiation therapy, that's when we sequence first the anemia code. So the anemia code in this case, when it's related to chemo, immuno, radiation therapy, the anemia code is sequenced first, and then the codes for the neoplasm, so that cancer, and then any adverse effects the patient may be having. So if it's, for example, T45.1X5, adverse effects of anti-neoplastic and immunosuppressive drugs. When the encounter, though, is for management of an anemia associated with an adverse effect of radiotherapy, anemia is sequenced first, followed by the appropriate code for Y84.2, radiologic procedure in radiotherapy as the cause of the abnormal reaction of the patient or later complication without mention of misadventure at the time of the procedure. If a patient's coming in because of that malignancy, they have dehydration, and we're managing the dehydration due to that malignancy, and only that dehydration is being managed, so like they're getting IV rehydration, the dehydration is sequenced first, and then we would follow that with the additional codes for the malignancy. If the patient is being admitted for treatment of a complication or resulting from a surgical procedure in regards to a neoplasm, designate the complication as that first or principal diagnosis if the treatment is directed at resolving that complication, not of the cancer, but at resolving the complication. Primary malignancy that is previously excised. So, for example, a patient that's had a mastectomy. When a primary malignancy has been previously excised or eradicated and there is no further treatment directed at that site and there's no evidence of any existing primary malignancy at that site, so if they've had it fully excised and there's no more treatment that they're getting, we would use a code from the Z85 category, which is the personal history of malignant neoplasm. Be careful when you're looking up those history codes in the alphabetic index, because the history codes, actually, since they go alphabetically, the next indentation is family. So you want to be careful that you're not accidentally assigning code for family history, that you're looking at the personal history codes. Actually, let me take a look at that in the book so I can show you exactly where that is. So if we're in our ICD-10-CM book here, when you're looking in your alphabetic index under history, so you go to your H tab and history, you can see the first indentation under history is family of. So don't get tripped up by that. Make sure that you're going out to the next indentation where it has the personal history. That's what you're looking for, personal history, not family history, because this is the patient's personal history of their malignant neoplasm. So when it's the personal history, we're coding something from Z85. Any mention of extension, invasion, or metastases to another site is coded as a secondary malignant neoplasm, and the secondary site may be the principal diagnosis or first listed with the Z85 used as a secondary code. Now let's talk about admissions or encounters involving chemo, immuno, and radiation therapy. When the episode of care involves surgical removal of a neoplasm, primary or secondary site, followed by chemotherapy or radiation therapy in the exact same episode of care, the code for the neoplasm should be assigned as the principal or first listed diagnosis. When the admission or encounter is solely for the administration of chemo, immuno, or radiation therapy, you would assign Z5 1.0 for radiation, Z5 111 for chemo, or Z5 1.12 for immunotherapy as that first listed or principal diagnosis. If a patient receives more than one of these therapies during the same admission, you may assign more than one of these codes in any sequence. The sequencing doesn't matter in that point if they're receiving more than one of these therapies in one encounter. The malignancy for which the therapy is being administered should be assigned as the secondary diagnosis after those Z51 codes. If a patient's admission or encounter is for insertion or implantation of radioactive elements, such as brachytherapy, the appropriate code for the malignancy is sequenced as the principal or first listed diagnosis, and code Z5 1.0 should not be assigned. When the patient is admitted for radiation therapy, chemotherapy, or immunotherapy, and then they develop complications, remember we talked about the Z51 codes, Z510 for radiation, Z5111 is chemo, Z51.12 in these cases where the patient has developed nausea, vomiting, fevers, whatever. What we code as the principal diagnosis would be those Z51 codes, and then follow it up with those codes for the complications, the nausea, vomiting, etc. When a patient is admitted for the purpose of insertion of an implantation of radioactive elements such as brachytherapy and develops complications such as uncontrolled nausea and vomiting and dehydration, the principal or first listed diagnosis is the appropriate code for that malignancy, and then any codes for the complications. I know this is a lot to take in, especially when you're thinking about, chemo or admission or what's the reason and sequencing and so forth. And again, I just want to remind everyone, medical coding is not about memorizing all the answers. It's about memorizing where to find all the answers. So if you're doing this frequently, you're probably going to have this particular section of the guidelines more memorized than maybe other sections of the guidelines. However, if you don't do it frequently, just know where in the guidelines you can find the sequencing regulations. That's the key thing. Admission or encounter to determine the extent of the malignancy. So when the reason for the encounter or admission is to determine the extent of the malignancy for a procedure such as paracentesis or theracentesis, the primary malignancy or appropriate metastatic site is designated as the principal diagnosis, even though chemo or radiation therapy is administered. Again, this is for when the encounter is to determine the extent of the malignancy. So even if they're getting chemo, that code that we're really treating is we're looking more so at the cancer for that encounter. So the cancer code, the primary malignancy code, or the appropriate metastatic site is sequenced first. Signs, symptoms, and abnormal findings as listed in Chapter 18 with an existing primary or secondary site of malignancy cannot be used to replace the malignancy as the principal or first listed diagnosis, regardless of the number of admissions or encounters for treatment and care of the neoplasm. So for example, if a patient has prostate cancer and they're having urinary symptoms, you would not use urinary symptoms as the first listed diagnosis when we are treating actually the prostate cancer. And then here it says admission or encounter for pain control management to see section IC6, and we'll go over that when we go over that specific guideline. Malignancy in 2 or more non-contiguous sites. If a patient has more than one malignant tumor in the same organ, these tumors may represent different primary or metastatic diseases depending on the site. Should the documentation be unclear, the provider should be queried as to the status of each tumor so the correct code can be assigned. Disseminated malignant neoplasm unspecified, code C80.0 is disseminated malignant neoplasm unspecified, and that's for the use in those cases where the patient has advanced metastatic disease and no known primary or secondary sites are specified. It should not be used in place of assigning codes for the primary site and all known secondary sites. Malignant neoplasm with specification of site. Code C80.1 is for malignant neoplasm unspecified, which is basically cancer unspecified. So really your providers should not be in a situation where they're not designating where the cancer is. So this would hopefully be used very, very rarely. Sequencing of neoplasm codes. Encounter for treatment of primary malignancy. If the reason for the encounter is for treatment of a primary malignancy, assign the malignancy as the principal first listed diagnosis. The primary site is to be sequenced first, followed by any metastatic sites. If the encounter for treatment of secondary malignancy, so in the case where we are treating the secondary malignancy, we can use the secondary site, if that's what we're treating, as the first listed diagnosis, and then the primary malignancy site actually goes as an additional code. Malignant neoplasm in a pregnant patient. So our chapter 15 codes for obstetrical stuff, they trump basically everything else in ICD-10. So our obstetrical codes take sequencing priority always. Encounter for complication associated with a neoplasm. When an encounter is for management of a complication associated with a neoplasm, such as dehydration, and the treatment is only for the complication is coded first, followed by the appropriate code for the neoplasm. The exception to this guideline is anemia. When the admission or encounter is for the management of an anemia associated with a malignancy and the treatment is only for that anemia, the appropriate code for the malignancy is sequenced as the principal or first listed diagnosis code, followed by D63.0, anemia in neoplastic disease. Complication from a surgical procedure for treatment of a neoplasm. When an encounter is for treatment of a complication resulting from a surgical procedure that was performed to treat the neoplasm, like maybe a lumpectomy, designate the complication code as the principal or first listed diagnosis. See the guideline regarding the coding of a current malignancy versus a personal history to determine if the code for the neoplasm should also be assigned. So if you remember, if we're still going to code it as an active cancer, there still has to be some sort of active treatment. If it's something that's been completely excised, eradicated, that's when we use the personal history codes. Pathological fracture due to a neoplasm. When an encounter is for a pathological fracture due to a neoplasm and the focus is treatment of that fracture, a code from subcategory M84.5, pathological fracture in neoplastic disease, should be sequenced first, followed by the code for the neoplasm. If the focus of treatment is the neoplasm with an associated pathological fracture, the neoplasm code should be sequenced first, followed by M84.5 for the pathological fracture. So again, that is for when it's the treatment of the neoplasm, and then they also have the fracture. Current malignancy versus personal history of malignancy. When a primary malignancy has been excised, but we're still doing further treatment, such as surgery, radiation therapy, chemotherapy, the primary malignancy should still be used until treatment is complete. So any kind of active treatment we're still doing on it, it still gets coded as cancer, not history of cancer. When the primary malignancy has been previously excised and eradicated from its site, and there's no further treatment being done of that malignancy, and there's no evidence that they have any existing malignancy anymore, then we can code it to personal history, our codes from that Z85 category. Codes from subcategory Z85.0 through Z85.85 should only be assigned for the former site of a primary malignancy, not the site of a secondary malignancy. Codes Z85.89 may be assigned for the former site or sites of either a primary or secondary malignancy. Now getting into leukemia, leukemia, multiple myeloma, and malignant plasma cell neoplasms in remission versus personal history specifically. The categories for leukemia and category C90, multiple myeloma, and malignant plasma cell neoplasms have codes indicating whether or not the leukemia is in remission. There are also codes Z85.6, personal history of leukemia, and Z85.79, personal history of other malignant neoplasms of lymphoid, hematopoietic, and related tissues. If the documentation is unclear as to whether the leukemia has achieved remission, the provider should be queried. So these ones here where it just says see these various sections, we'll go over those when we go over those very specific sections. Malignant neoplasm associated with transplanted organ. A malignant neoplasm of a transplanted organ should be coded as a transplant complication. Assign first the appropriate code from category T86, which is complications of transplanted organs and tissue, and then assign the code C80.0 8.2, malignant neoplasm associated with the transplanted organ. Use an additional code for the specific type of malignancy. And then chapter 3 actually doesn't have any current guidelines in it, so we won't have to go over the chapter 3 guidelines. Next week, we will actually be starting with chapter 4, which is endocrine, nutritional, and metabolic diseases. So that's a lot of diabetes regulations. I'm going to actually show you page by page through some of the stuff in the book in regards to diabetes and the sequencing for that and the cause and effect relationships that we have with diabetes. I hope you found this video helpful. Make sure you come back next week when we'll be going over more of the chapter-specific guidelines for ICD-10-CM. If you are enjoying this content and you found value in it, make sure you give me a big thumbs up and don't forget to subscribe and hit that notification bell so you can get alerts when I post new episodes. I will see you in the next episode, and until then, just keep on coding on.